Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City. Before we get started, I should mention that the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, or the institutions of any of our guests. Today, we have an episode on a topic of interest to almost all shoulder surgeons, which is how to rehabilitate the injured shoulder in an athlete. And I've invited two world-renowned experts to discuss. Both of our guests have worked with a large volume of high-level athletes from multiple sports. They've succeeded in getting back to play. So first, we have Kevin Wilk, who's the head of Champion Sports Medicine in Birmingham, Alabama. Kevin, welcome to the podcast.
Great to be here, Dr. Chalmers.
And then next we have Stan Conte. Stan is the former trainer of both the Giants and the Dodgers and is currently the Senior Director of Medical Services for the Marlins. Stan, welcome to the podcast.
Yeah, thank you. Thank you for inviting me. This will be fun.
Okay, let's get started. So how did each of you get involved in rehabilitating the athletes? So Stan, tell us, how did you get involved in this field?
Yeah, I started in private practice way back in the 1980s and had a couple private practices that saw some sports medicine, high school, college, and eventually started seeing a couple professional athletes. And at the time, the San Francisco Giants had one athletic trainer, and they asked me to start seeing their disabled people. And then eventually I ended up working at the Candlestick in San Francisco with the Giants. And somehow I forgot to go home, and I kept going with the Giants for 14 years and then on with the Dodgers. So I kind of started out like most people, seeing a lot of different type of athletes, and then eventually kind of concentrated on the professional ranks.
And what about you, Kevin? How did you first get involved with treating athletes?
Mine's pretty similar to what Stan mentioned. So I started in the mid-'80s as well, and started right off in sports medicine, a small practice. And from there, I progressed to a different practice in Chicago, who the physicians I worked closely with took care of the Chicago White Sox. So at the time, just like Stan said, in the 80s, it was pretty unusual to have multiple trainers or PT. I think the Dodgers were probably the only ones that have a PT on staff at that time. So the White Sox had, I think, two trainers at the time, maybe a part-time third, I think. But at any rate, they asked me to do some of the rehab for the guys who were staying behind, not traveling, those types of things. They kind of evolved over the next couple of years. And then I met a physician, Dr. James Andrews, at a conference, and he talked me into coming down to Birmingham, convinced me that they were building a big sports medicine program in Birmingham, Alabama. And I came down here in '89 and have been here ever since. And as a result, obviously with Dr. Andrews, we see a lot of baseball players. I had a couple consulting positions with the Rays, the first Devil Rays and then Rays. And now just basically we just see independent players. Dr. Andrews at the time was a medical director for the Tampa Bay Devil Rays.
I wish I could go back in time and be present at the meeting where you and Jimmy Andrews met each other. Is there a story there? Tell us what that was like.
Oh yeah, absolutely. There's a long story. I'll try to paraphrase, but we were in Cincinnati at the Dr. Noyes meeting, and a friend of mine, Bob Mangine, was running the meeting, and he knew that I was going to leave Chicago. I had interviewed in New York for a job, and I interviewed at UCLA in LA. And I liked both. And I said to Bob, I'm going to move. I'm going to leave Chicago. I'm just trying to figure this out. Do I want to live in New York and work with those guys, or go out to UCLA, who was building a program? And he said, well, first you need to talk to Dr. Andrews. He's building a program in Birmingham. I didn't even really know where Birmingham, Alabama was, to be honest. I was a Chicago guy, and came down a couple times and visited. At the time it was Health South, and Health South was just starting out. And the irony of that whole story is, as a result of me taking that position, I met Stan. And Stan and I were on multiple clinical programs for Health South as far as protocol development and outcome studies. And Stan and I often sat next to one another at those meetings for several years, right, Stan?
Yeah, that's interesting. What you're leaving out, though, is there was a time that you came out to San Francisco, entertaining a potential job out in San Francisco. I think we showed you Candlestick, and you ran back to Birmingham. But yeah, that was, I do remember you coming out and looking for a position out in beautiful California.
Yeah, absolutely. That was a great trip. I remember hanging out with you at Candlestick and loved it, and would have taken that job until I looked at houses and couldn't afford the garage part of the house.
Yeah, I think it's really interesting. I hadn't really thought about until we started talking here is the number of people, clinicians, that end up being friends and collaborating on different studies and doing different things over the decades, which has always been kind of fun, and makes the United States a little smaller, which is nice.
Yeah, absolutely. And, you make some of your best friends that way too, collaborating with these studies and going to meetings and the camaraderie and so forth.
I wanted to talk a little bit about that. I mean, I think one of the real insights you could probably give our listeners, many of whom are surgeons, is how to collaborate as a surgeon with a therapist, especially when it comes to getting an athlete back to play, someone where you really need to be in depth with the rehab, you want to be specific with the restrictions. You guys have worked with a huge variety of surgeons. So what I want to hear is, what are the surgeon habits that are most helpful, and what are the ones that most hinder the athlete's rehabilitation in terms of communication, in terms of how the protocol is written out? Tell us, Kevin, what are your thoughts?
Yeah, I think that's a big component. And, I've done this a long time, just like Stan. I'm sure he can speak to this quite nicely as well. We've seen the best, and we've seen probably some of the ones that we wish could get a little better with it. But it's availability, accessibility of the MD. It's the team approach, which is always a cliche. It's communication. Communication is the key. And, quite honestly, I think I've worked with the best. I'm a little biased, but Dr. Andrews, for instance, you could call him on a Sunday. You're seeing a patient on Monday morning, and he did surgery on them on Friday. And, well, it wouldn't happen that way. Actually, he would have called me on Friday night to tell me what's going on. I've never seen anybody more accessible and willing to share information than Dr. Andrews. And as a result, I think patients love that. They know that when they see that therapist, whether it's me or somebody else or Stan, if it's one of his players, you've already communicated with the physician. The physician told you, hey, I did a slap repair, but they realized that the slap repair, was a little bit larger, it was a peel back and 3 anchors, but the cuff was a little beat up and had a little bit of changes on the humeral head. The stuff you don't have in op reports. And also, for me, working with a Dr. Andrews or a Dr. Dugas or Dr. Kane, they give me their opinion a little bit. You know what I mean? Hey, on this one, it was a little stiff in the OR, like an ACL patient I'm dealing with now that's a pro basketball player. And even the OR, the ACL, after they put it in, the range was a little stiff. Hey, just so you know, this is what I'm struggling with, or wasn't that comfortable with the meniscus repair, so go slower. It was a big root tear. Those are invaluable information points that if I went somewhere and I didn't have that, and sometimes we get outside referrals, and it's, they don't, the physician might not answer the phone or they don't get back to us. You almost feel a little lost, if that makes sense, because you're so used to knowing the ins and outs of the surgery or what the physician is thinking. It really makes my job a lot easier. And to be honest with you, or I shouldn't say honest, I should say to be very direct with you, in my mind, I think that ensures a better outcome for the patient.
What do you think, Stan? What else would you add? Yeah.
Yeah, I think Kevin really hit on the main porch. Maybe I'll look at the other side. Communication is critical. There's no doubt about that. And I think in general, it's about staying in your lane. In other words, a physician does the surgery. I would not tell the physician what surgery to do or how to do that technique. And the same goes for the rehab. The expertise in rehab and early rehab, middle rehab, and return to play is under the preview of the physical therapist or sometimes the athletic trainer. And one, there has to be a lot of confidence between the two, and that gets to the communication and gets to know people. It's interesting, and I'll tell this quick story, and it's been public, so I'm not giving away any secrets. I had an opportunity to work with Neil Elatraj in Los Angeles with the Dodgers, and also with Frank Jobe. He was kind of walking away from baseball because he was, a little bit ill, and Dr. Elatraj took over as a team physician, and he had not really been a team physician before, and he came in and he started telling us what to do. And he and I eventually had a little conference in the back room where I said, listen, you're a great orthopedic surgeon, and you're a great surgeon. I said, you're going to have to let me teach you how to be a team physician and what it takes to be that. Neil kind of looked at me like he was about to punch me out. And he said, well, what does that take? And I said, let me tell you how this works. And he and I work together with the players. So it is not the doctor's patient, and it's not the therapist patient. It is the group, and Kevin said it, the team approach, which is a cliche, but it very rarely happens. And once you have that synergy and the ability to talk with the physician, and also the physician being able to talk to you, then it works really great for the patient. And when something goes bad, both people are engaged in trying to figure out how it's fixed without pointing the finger at anybody. And it's, in the professional level, it's critical. And I have had physicians who didn't do that, and the outcomes were easily not as good.
Certainly, I think the latter can be really important when it comes to return to play and the decision as to when someone's ready. So I want to talk a little bit about kind of this clearance for return to play and how we make those decisions. And certainly, I think there are certain parameters of, we know this injury takes this long to heal, but also there's, the functional aspect to it. So tell me a little bit about what you're using as your criteria for return to play and how you're making those decisions, specifically for shoulder injuries. What do you think, Stan?
Well, I think, first of all, the return to play sometimes is talked about as the end point. It really isn't the end point. The return to play starts almost right after the surgery. So one of the things that we've learned is, yes, the shoulder is important. It's had an operation, but as we see a lot, the shoulder is an innocent bystander a lot of times in regards, especially on pitchers, because of the kinetic chain. And so one of the things that looks in return to play, as opposed to the criteria, is, what are you going to do to get them to that point where they can actually start doing baseball activities? And that starts at the very beginning of what you're doing. And if it's a 6-month rehab thing, it really starts right when the rehab starts. So you can start working on core, you start working on hip and other areas in the closed kinetic chain, in order that when the shoulder is ready, everything else is ready. So that's a real important part of this whole thing. But as far as criteria go, at the professional level, it's relatively easy because you're right with the baseball people every day. So, as you start to get the range of motion, the strength, and the scapular, making the scapular work, which I think is probably more critical than anything else in the shoulder, before you get into that, you're able to literally walk outside and you have a field. So you can start running programs, you can start doing those things. We do a lot of plyometric work to determine from a shoulder standpoint when they're ready to actually start tossing a ball. And the progressions on that are general, but they have to be very specific to the other thing. So eventually, at the professional level, we're able to actually get them in simulated games and then rehab games to see if they're ready to actually get back to full activity at whatever level, minor league or major league, that they're able to do. So it's very easy at the professional level. I'll turn it back over to Kevin, because Kevin works with people that he has to do long distance, and not necessarily a field right there to go out to. But that's kind of what I look at right from the beginning. I'm looking at the kinetic chain, and the shoulder is part of it, and we concentrate on that early. But at the end, if the kinetic chain is not right, then you're going to end up with the same problem you had prior to surgery.
Yeah, I think Stan brought out some great points, and I couldn't agree more. I think it's critical, and also to Stan's point, it's a little different when you're in the team environment versus a physical therapist or athletic trainers working in a clinic situation where people are coming and going. It's a little harder to manage because we have limitations in visits and, as far as number per week, things of that nature. And there's other variables that come into play for the outpatient rehab setting, such as coaches, the family. Sometimes it's hard to control that. But as far as our criteria to go back, couple things. One of the most important ones is to be on the same page as the physician. I just had this conversation the other day with a doctor after a UCL reconstruction. And this young man plays professional baseball. He's in minor leagues. He's getting ready to go to Arizona here in about a month. And he wants to know when he can start throwing. So I'm not going to answer that question in isolation. I have to call the physician, see what his mindset is. I have to call the organization, talk to the rehab coordinator or the head athletic trainer and say, what is your philosophical approach in your organization, but also for this individual time frame. He's not going to pitch this year, so obviously he has a lot of time. He's 4.5 months post UCL. He's anxious to start throwing. He looks great, and so what we do is we go through a functional test series so we can report that back to the physician and the trainer or the rehab coordinator. But that decision in that pro athlete time frame is made as a team. I don't want to say, if you know what I mean, I don't want to say, hey, we start you at 4 months when the physician says, no, I wanted to wait till 6, and the organization said, well, I wanted to wait till 5. Do you know what I mean? It would be a very mixed message and would make us not look very good as a team approach to it. So that's some of the nuances behind the scenes that I think a therapist, athletic trainer working in a clinic situation outside the organization has to consider. For us, we look at range of motion, obviously. We look at clinical exam, let's say if it's an elbow or a shoulder. In this case, I know this is a shoulder podcast, so we would do special tests that we think were appropriate for us. If it was a slap repair, do some type of slap test, something like that. We would do a strength test. Years ago, I used to do isokinetics. Now I use more handheld dynamometry. I look at ER, IR, deltoid strength, and the 4 movements at the scapula: elevation, depression, protraction, retraction. And I generally look at bilateral but unilateral muscle ratios. Down here in Birmingham, it's a big thing with the Andrews group that all these individuals have done plyos before starting a throwing program. So I've got to make sure that this athlete has done plyometrics. And it's just like saying, well, you did your rehab. Just because you say you did plyos, I want to know what plyos did you do. And to Stan's excellent points about the kinetic chain, that means 2-hand throws with rotation, using your hips, engaging your core, those types of plyos. Then we do what we call ball drop testing. Person lays on the table, arm is up at 90 degrees, 2-pound ball. They drop and catch it 30 seconds. We count the number of drops and catches. So they drop it, catch it before it hits the ground. And we would compare that to the opposite side. We would want a 10% increase versus the non-throwing shoulder. Then we do a ball throw up against the wall. It's a 2-pound ball, and they basically throw it baseball style up against the wall. They're very close. They do it for 30 seconds. They do it on their throwing side or injured side and their uninjured side, and we look for the difference. Again, we want 10% greater. Then we ask them to do a single leg squat test. We put a chair behind them just in case they lose it. And we see in 30 seconds how many single leg squats you do one side to the other. We have some normative data on that. And then lastly, we do a plank test. Prone on elbows, toes and elbows, they plank, and we count the minutes or seconds that they're able to plank. We're looking for anywhere between 60 to 120 seconds. We add up their scores. To date, I'm looking at it right now. We have tested, oh God, I just lost it. Sorry about that. We've tested 281 healthy players and 98 UCL repairs or reconstructions. So we have a pretty good database as far as this for normative, and it's at various levels, professional, high school, and college.
Certainly those kind of tests are so useful for the listeners to understand, like, because a lot of those are things you can pretty easily do in clinic to test. I wanted to talk, a little bit about the shoulder and throwers. Both of you have such a wealth of experience getting throwers back. As a shoulder physician, I think one of the more difficult patients to see in clinic can be the thrower who comes with shoulder pain who's kind of just working through internal impingement. There's a little bit of cuff tendinitis. There's a little bit of posterior superior labral fraying. It's a player who's saying, my shoulder hurts, I can't throw. But you look at it and you think, this is not surgical. This is not like there's something structurally torn. This patient has just a shoulder that needs to be basically tuned back up. So I wanted to get at a high level, when I see this patient as a surgeon, what should I emphasize to set that patient up for success when they come in and see the therapist to start really working on that? What are your thoughts, Stan?
Well, I think first of all, you have to evaluate the player first to see exactly where he is, range of motion wise, look at deficiencies and that type of thing. Now, I will tell you though, to get maybe a little bit more general, if the guy has an internal impingement, I actually start working with the pelvis first. I know that seems crazy because he's got a shoulder problem. If he's a thrower, the question is, why did he end up with an internal impingement? And the two areas that I've spent a ton of time on is the pelvis, not as much the core. I mean, the core has to be stable, but the lumbar spine shouldn't rotate much at all. The pelvis is what rotates. And so work on that type of movement pattern and how to activate muscles in the lower extremity to get the pelvis to rotate. And when you start looking at biomechanics on this, you can see that if the pelvis does not rotate or it takes a long time to rotate, then shoulder hip separation does not occur. And then at the end of that chain is that poor shoulder that's got to do more work than it's designed to do. So we work at that. The second part is we go after the scapula. And I believe for years and years and years, I've totally missed the point on the scapula. And we think of a head of the humerus on the glenoid and lack of internal rotation or anterior impingement where the head of the humerus is there. I actually look at it differently, and that is it's not the head of the humerus on the glenoid, it's the glenoid on the humerus and where the scapula is. And so what we do a lot of is concentrate a lot, and when I say a lot, I'm talking about a lot of reps, a lot of volume, and a lot of resistance training to the serratus anterior. The serratus anterior is a key muscle. When you look at baseball, whether it's a pitcher or whether it's a hitter, in my view, it's almost all protraction. So what we do in strengthening the scapula, for instance, is we do a lot of retraction, which definitely strengthens the scapular muscles. But in baseball, if you look at this, if you look at a hitter and you look at a pitcher, they're not over the top. They're not at 90 degrees of flexion. They're at really about 90 to 100 degrees of abduction. And when you look through that, what they have to do is protract the scapula, not upwardly rotate it. And so I think that we end up having the upper trap that works and should be quiet and not fire at all and be able to protract. So we spend a ton of time working on the pelvis and the scapula, not for just a period of time, but we put it in their program. And what we'll do is do a lot of exercise compartments, if you will. You do three sets of one series of exercise, another one. You might do that 3 or 4 different groups, and each one has a serratus anterior and a pelvic muscular exercise that goes into that. And then when you start getting into the plyometrics, you end up actually teaching them how to move the way that you should in order to throw a baseball and to hit. So those are the 2 areas I look at. Now, obviously, you work on the shoulder, especially after surgery, but if they're having that, you're looking at rotator cuff strength. Everything that Kevin talked about, you have to, that's definitely the minimum standards to be able to decide where you're going to do that and analyzing what is weak and what needs to be strengthened in your program. But I can tell you, we've seen internal rotation deficits decrease just by putting the scapula in the right place and being able to dynamically be able to protract and increase interrotation without stretching or doing anything like that. So that's kind of the way I approach it.
Now, Kevin, I know you've done a ton of research on this concept, GERD, and I still hear people say, oh, the problem is GERD, and that's the cause of internal impingement. Tell us your current thoughts on GERD. Does it play a role in internal impingement? And then I'm also, you taught me a great exercise for serratus. I'm hoping you can share with the listeners.
Yeah, a couple things. With internal impingement, just as what was alluded to by Stan, I mean, it's so faceted. And what I mean by that is, if I see a high school kid with internal impingement, they present many times differently than a professional. Or another sport, for instance, like volleyball, for instance, which is pretty common to have similar complaints of posterior pain right at the infraspinatus at the joint line, sometimes even tennis players. So it depends many times for me how the athlete looks physically, if they're developed, believe it or not. Like a high school kid many times is underdeveloped, has hypermobility and maybe throwing mechanics. Versus the pro that really needs maybe a little bit more fine tuning. But, our approach to internal impingement is we try to attack the area. So it's a little bit different than what Stan portrayed, but we do the same thing, but just maybe in a little different order, is we try to diminish the pain and inflammation posterior. So sometimes a surgeon, a physician that saw the athlete might even inject the posterior shoulder, which I'm perfectly fine with. If they don't, we'll use laser therapy or iontophoresis, ice to calm that area down. We want to take a look at the range of motion. We do look at GERD. I factor it into the equation. I look at horizontal adduction. I factor that into the equation. I look at total arc of motion, ER and IR added together, and that's probably the most significant for me. And I'll even look at shoulder flexion. I look at their strength ratios, posterior cuff to anterior cuff. I look at the scapular position. I think that's critical, as was mentioned. And so we work on getting your cuff ratios back, working on scapular control, work on core, hips, as you heard before, and legs for that matter. Try to promote some tissue healing, but really emphasize proprioception, good posture during throwing, good throwing mechanics, and a gradual return. So for me, it's normalizing the motion, scapular position, and dynamic control at end range ER. So key exercises are fast movements like throwing a plyo ball up against the wall with a rhythmic stave at end range ER, plyometrics into a rebounder, higher speed with end range ER stabilization, resistance bands, faster speed ER with end range stabilization, because their symptoms with internal impingement would probably be leg cocking, early acceleration. They may have some in ball release and follow through, but most of them complain of leg cocking and acceleration. So that's my approach to internal impingement. I know it was a little lengthy, I apologize, but this takes time to address it and unravel it. Many times these people have other concomitant things like a weak right hip, or on the throwing side, hip weakness or scapular malpositioning, lack of control of their pelvis, as Stan talked about. So all those things I think need to be evaluated and treated.
Let me add a little bit to this in regards to everything that Kevin says is absolutely, in regards to the exercise program, is minimal. But one of the things that bothered me over the years is that at spring training, everybody does a physical, the orthopedist does a physical, and he has them raise their arms up and go into flexion and everything else. You look at, then there's winging of the scapula, the inferior angle goes this way, then everything goes that way. If you did that at the end of the year, it looks exactly the same, in my experience. There doesn't seem to be any correction. Everyone's doing scapular exercises, they're doing everything else. I can't say enough about rhythmic stave and stability and all the stuff, because it's an unstable joint to begin with. But again, one of the stuff that we do a lot is closed kinetic chain work with the scapula. And that is a bear crawl, different types of bear crawls, different type of tubing in regards to activating the serratus. What happens a lot of times on these exercises is the serratus really doesn't work if you're not doing the exercise correctly. And so coaching and being able to get the right technique to do it the right way to actually strengthen the serratus and have that athlete be able to feel that his serratus is working from a baseball standpoint. It's not true of every sport, but in baseball, because I think protraction is so important that then you're able to then get that normal functional movement of the glenoid on the head of the humerus. And so, and we do a ton of that in regards to the closed kinetic chain aspects, as well as the other things. We sure do retraction and a lot of the stuff that way. And then I guess I would ask Kevin too, when you talk about proper posture, what does that look like from you from a pitching standpoint? I don't mean to take your job, Peter, on asking questions, but I heard that, and I'm interested to hear what Kevin's got to say about posture.
Yeah, I think, posture comes into multiple definitions or functional activities. So the very basic would be how the person walks in the clinic and negotiates at a very low level activity, like just taking a shirt off or just walking in. So if they have bad posture with that, I'm going to address that. And to your point, I think where you're getting is, what is the posture during pitching? For me, the test that we use for scapular dyskinesis that was popularized by Kibler and McClure and those, I think, are good tests for everyone except the overhead athlete. Because in my opinion, scapular dyskinesis exists in almost all pitchers. The situation is, how much do they have and can they control it? Just like internal impingement. I think Dr. Jobe and others have shown that internal impingement happens in cadavers. Internal impingement happens dynamically with MRI, that you kind of fluctuate in and out of this symptomatic episode, and so we try to calm it down and progress out of it. So as far as the posture, as far as throwing is, we try to make as much corrections as we can as far as you're in what we think from a biomechanics lab standpoint, what that normal range is. So they're not all going to be the same, obviously, but it's going to be in a range. Just like saying somebody needs X amount of degrees of external rotation to throw, it's that range of external rotation. So for me, just as you said, the scapula is critical because the serratus is actually the second highest level of EMG activity in the whole body in the thrower, only followed by, or only muscle group ahead of it would be the wrist flexors, followed by the serratus. So the serratus is critical. And so obviously, because the serratus is protracting, the scapula is moving forward, and you'll see that medial border come off when they're doing plyos and things of that nature, and the follow-through phase of the throw, which I'm perfectly fine with as long as it doesn't get outside that range. So for me, I grade scapular dyskinesis 1 through 4. You got a little bit of it or you got a lot of it, and I want my thrower to be a 2-3, if that makes sense. If you don't have enough, I think your shoulder is going to see more forces, because your scapula, if you look at someone throwing without a shirt on and they ball release and follow through, the scapula literally protracts, upwardly rotates to a degree, but it elevates and it moves in this kind of diagonal pattern. It's coming off the thoracic wall. And if it doesn't come off, that means your shoulder joint is seeing all that stress. It's like having multiple springs.
I think one of the big things that you just said, which I think I finally recognized after 20 years of doing it wrong, is that the scapula in the throwing shoulder is different than anybody else, and that makes the difference. So if you're working on, pitchers and baseball people, it's not the same as a posture with a different sport. And again, I'm a little bit more straight protraction and keeping them there and making sure that medial border doesn't work. But it's in the rehab that it occurs. But it is really difficult to get that scapula to stay floating in that rib cage as it comes around. And when you look at a pitcher and you look at a hitter and you do it in slow motion, you kind of see exactly what they do. And I can tell you from working with pro athletes, when you actually talk about the serratus and talk about where the scapula is going, and you show them how it's supposed to work, and they start doing it, they go, yeah, that's what I need to do. It was amazing to me several years ago when this was introduced to me that the athlete knew right away. Now I feel like I'm where I need to be from a pitching or a throwing standpoint as far as my shoulder and my scapula specifically.
And Peter, to
somewhere right
go
now,
back on your,
please.
Sorry.
I was just going to say somewhere right now, Ben Kibler is preparing his rebuttal to your statement that everyone has dyskinesis. But please, what were we going to say?
Oh, well, the good part is we're doing a webinar tomorrow, Ben and I, so he's going to hear it tomorrow morning.
Okay.
And so we'll see what he says. But
okay.
To go back to your question regarding the best exercise for serratus, if I could. So for me, I mean, the best exercise, or one I like, not maybe the best, because the best is depending on who they are, what they're doing, and things of that nature, is I like the wall slide. And we do multiple variations of it. So person basically is planking up against the wall, almost like in a push-up position, but their elbows and forearms and the ulnar aspect of their hand is on the wall, and they slide up and they slide down, so they're protracting into the wall. And we like that a lot. And I'll add resistance bands. I'll add manual resistance, especially in the lowering, the downward rotation. So the resistance band is actually resisting protraction. I'll also do some quick punches with resistance bands as well, almost simulating like a throwing motion. So their arm is up at 90 degrees, and I'll be behind them with some resistance bands in their hand and also the shoulder complex, and just right over the anterior aspect. And they'll do like a punch forward, but simulating kind of the ball release follow through, which I think is, again, important for the serratus because it's so critical in the throwing motion, as Dan was mentioning.
Yeah, I'd go back. The reason I make an emphasis about bear crawls and close kinetic chain is many people don't think about utilizing it. And for us, it has been a way to really isolate the serratus. And when you have someone get into a bear crawl position, just up your knees and on your hands and pushing down into the ground, you can see if that medial border right away gets away from the rib cage. And then as they get stronger and they're able to hold that, then as they start to essentially crawl forward, move forward, you'll see after 2 or 3 at the beginning how the serratus fatigues, and now you see that medial border. And then that has to be corrected. And one of the things that we're seeing a lot more is the coaching, whether it be a strength coach or whether it be an ATC or a PT, is not let them do an exercise incorrectly. And we see this all the time, especially at the pro level. You walk through a weight room and you see a guy doing a lift that's wrong. And sometimes the person who's watching that doesn't correct it, and they have to stop and correct it, because what you're doing is producing bad movement as opposed to good movement from a brain standpoint, and being able to get that pattern together in your head and make it reproducible. So dyskinesia, if you will, or scapular dyskinesia, feels bad, and true protraction and doing out is it feels right. And so they know when they're messing that up. So that's kind of what we do. And that's just a takeoff, again, on some of the other things that we do to stabilize the joint itself.
Let me just elaborate just for 1 second, Peter, if I can, about this concept of throwers or pitchers, overhead athletes have some degree of scapular dyskinesis. And the reason they have it is because they're hypermobile to begin with. And so this could be a gymnast, this could be a baseball player, this could be a volleyball player, a swimmer. These are individuals, once they reach a certain level of expertise, they've reached that level because of hard practice and everything else and coaching, but probably to a large degree, a genetic predisposition. Classic would be like Michael Phelps. Michael Phelps is Michael Phelps. If you looked at his elbows, they hyperextend about 30 degrees. He's very laxed. He's got unbelievable training, mindset or determination, and he's a very gifted athlete. But his genetics is that hypermobility, which makes him a fantastic swimmer. And I think that's the case with a lot. I'm not going to say 100% of overhead throwers, but I'm going to say a high percentage of those individuals. And by the definition of it, it's just an alteration compared to the opposite side. It doesn't mean that your scapula is moving, 5 centimeters. It just means it's different than the other side, which probably isn't a fair comparison anyway.
I wanted to ask each of you real briefly, we've got this discussion of the scapula and the serratus is awesome. And I think a lot of orthopedic surgeons are going to listen to all this and really engage with it because I think it's so important. One of the things that I want to ask you is, you guys have seen a huge variety of injuries. What is the injury where when the patient walks through your door with this diagnosis or after this procedure, you just feel with dread? Like what is the one that challenges you the most? What's the one where you wish the surgeon would adequately warn the patient this is going to be a difficult recovery? So what do you think, Stan?
Well, I think that about all shoulder injuries that come in, because the biggest problem with the shoulder is what the pain generator is. And we've seen study after study that looks at asymptomatic pitchers with all kinds of terrible stuff on their MRI, yet they pitch for 10 years with hardly any problems. And so, I think that's the biggest problem, is trying to do that. So if a guy has a labral tear and he goes back posteriorly, we're not talking about the classic slap from 2 o'clock to 10 o'clock that may be a natural adaptation for getting extra rotation, or it could be pathological. But when it starts to go more posteriorly, if in a pitcher, it starts to increase. Is that the pain generator, and how does that affect the rotator cuff? And typically, you've got 3 or 4 things in the shoulder that are could be symptomatic. So I think one of the things for me is I want to know before the surgery why you're going after that particular structure, and then of course once you get in there, you kind of look to fixing whatever you see if it's significant. But again, 15 years ago. There was a lot of slap tears that were repaired when they probably didn't need to be repaired. So for me, the scary part is, did we get everything, or did we do too much on anything? And that's really for me the art of the surgeon, not just the science behind it, but the art. As they're inside the joint and looking at the structure, they said, well, this is causing the problem. And that's harder than it sounds, because when you scope the shoulder, you see all kinds of things in there that could be the pain generator that's causing the problem. And prior to surgery, one of the things that we've used a lot, and I'm sure other teams do, and other surgeons do, is if we're not sure, we'll do selective injection and make it a diagnostic. Inject the AC joint, the subacromial spot, and the glenohumeral joint to see if you can reproduce the pain before, does it go away with the lidocaine? And that way you can really get the pain generated, as opposed to the elbow, which is pretty easy to figure out what is going on in the elbow. The shoulder is a lot more difficult. So when that guy comes in there with a shoulder, after shoulder surgery, hopefully I've talked to the surgeon. He's already told me what he was going to do before the surgery, or I go to the surgery to see the surgery to have the decisions. I think that's what scares me so much, not necessarily a labral repair or even a rotator cuff repair. That doesn't scare me as much as did we get the right thing.
What are your thoughts, Kevin?
Well, I'm scared with rotator cuff repairs in a thrower. So, but I would say non-operatively, the ones that are difficult for me would be thoracic outlet in particular. Sometimes they can be tough to chase. Sometimes lat strains, high-grade lat strains, are very difficult at the shoulder. As far as post-op, I don't really see that many. I see very few shoulder surgeries in throwers nowadays when I compare that to years ago in slap repairs. So for me, if I see a shoulder surgery in a thrower, I'm concerned. Probably my biggest, when I say concern, it just means my radar goes up and, I've got to really reel this player in, this athlete in, and make sure they're doing everything possible. But for me, probably the cuff is the most difficult. Early on, it's not that bad. It's not even that bad starting a throwing program. But once they get back to high-level throwing, because of the forces going across the cuff, they usually have complaints of pain. They're very difficult. Pitchers, after cuff repairs, as we know, according to literature, is a very low number have made it back. Position players, not that concerned about. I think I've had good success with it. Non-throwing shoulders because of traumatic injury to the cuff, not a problem. But pitchers, gradual onset cuff failure is a big problem. And then a little bit with slaps, only because I think the slap tear, the classic peel back, is an adaptation. So obviously our concern is that they don't become tight afterwards, that we move them right away, we get their motion back. We did a study in our biomechanics lab here with Dr. Fleisig where we looked at slap repairs. And on the table, their motion looks good, but when they throw, they say they feel tight. And they lose horizontal abduction, and they lose external rotation, which gives them a loss of ball velocity and just the ability to generate force for distance. So, I'm concerned with anyone that has shoulder surgery.
I think, Peter, you wrote an article on shoulder surgery in baseball using HITS data, showing after surgery in all shoulders about 37% return. If I'm quoting that wrong, please correct me. But but I think there are more times when you do see a full thickness rotator cuff, which is typically death to a pitcher. We're seeing some of those guys come back. One, because of the technique of reattachment into the footprint, and I think they had a better chance from a structural standpoint. Yet still, the outcomes are not great. But on a guy who wants to take a shot at it, he's got a better shot than he did 10 years ago.
Well, that's all about the time we have for this podcast. I really want to thank both of you for coming on. You guys are both awesome, and your insights are going to be super interesting to our listeners. So for all of our Shoulder Elbow listeners out there, don't forget to subscribe, and we will see you next time.
Hi, I'm Grant Garrigues from the American Shoulder and Elbow Surgeons Technology Committee. I am so excited that you're enjoying the ASES podcast. It's one of my favorites too. There's many places you can get the podcast, but one place that might be convenient for you with other similar content is the ASES app. So that's right, ASES can be right in your pocket on your smartphone. You can download it from the App Store or either Apple or Android App Store. Just look for ASES and the ASES logo. You'll need your ASES login to enter, which you can get from the ASES, and that'll allow you to unlock all the member benefits and member features. Some of these features are the ability to connect with other ASES surgeons, find out about upcoming grant opportunities, abstract deadlines, and meetings. And eventually, as the content grows and grows, we'll have more than just this fantastic podcast. We also have recorded lectures, videos, and other media. So check out the ASES app. Let us know what you think, and enjoy all that ASES has to offer through the app. Thank you.
Grant, how much does the app cost?
The app is free.
Well, Grant, we appreciate all the work you guys have done on the app. It sounds awesome. And I think that all of our listeners should go check it out, because certainly it's just another way to access this content as well as other content that's similar to it that I think you would enjoy.